بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين سيدنا وحبيبنا ونبينا محمد. Welcome everyone to our today's presentation. We are continuing sonographic anatomy of the breast. Our education objectives is to review the basic breast anatomy and to discuss how anatomy influences the detection of breast abnormality and to diagnose breast diseases and conditions. As we said before, beside all advantages of breast ultrasound, it is crucial for us because of our limited mammographic facilities. So we have to study and study and study. Okay. As we mentioned before, we have 5 mammographic densities or X-ray densities. Air and fat as lucent, and calcium and metal as hyperdense, and in between we have a water density. Corresponding to this water density on mammography, we can find anechoic ultrasound lesions, hypoechoic, isoechoic, or hyperechoic as seen in these examples. This is a soft tissue or a water density lesion on mammography. Corresponding ultrasound demonstrate cluster of cysts. And also we mentioned the basic anatomy of the breast composed of a glandular part which form of lactiferous duct sinus and lobules. These embedded into stroma, into the fat and supported by the stroma, both together representing the parenchyma. And any distortion, destructions, abnormal size, abnormal number, or echogenicity of these structures will result in abnormality and breast pathology. Also, we mentioned the scale of echogenicity, and we said that we have to adjust our ultrasound setting, putting the fat in the intermediate grade because it is our frame of reference. And we mentioned that we have normal structures more having echogenicity more than fat, and we call it hyperechoic. And we have structures less than fat, and we have those equal to the fat, and we call it isoechoic. And any lesions having echogenicity less than fat, it will be hypoechoic or anechoic in extreme to the left. And we said this is important because most of the cancer in this region. Regarding the anatomy, here we can see the periductal stroma and lobular, intralobular stroma as gray, iso to the fat. And this echogenic is a compact fibrous parenchyma. Also, the skin is hyperechoic. Okay. As you know, we have 2 pairs of breasts resting on in the chest wall and pectoralis major muscles, and from the intercostal, second intercostal to 6 or 7 intercostals, and from the mid-axillary line to the sternum, but there are variations, can extend up to the clavicles or below the 7th intercostals, or medially can extend even more. We have experience of we have experience of detection of breast cancer in extreme lateral chest wall, demonstrating that some of the breast tissue can extend more extreme laterally beyond the mid-axillary line. As we mentioned, we said that, as we mentioned before, we said the parenchyma of the breast composed of a glandular and stroma, and we mentioned different structures. Here we can see intralobular stroma as gray, while the interlobular stroma is white. We have periductal stroma is gray, compact stroma, okay, representing the perilobular and mammary fascia, suspensory ligaments. All these are bright or white, okay, and the fat is gray. So the combination of these structures giving a heterogeneity of the breast parenchyma on ultrasound. And there are variations of these components from one breast to another breast. And as you know, there are many factors affecting these, including the age, race, and so on. Looking at these examples of the parenchyma, can you see how they look different? See, look, all are fibroglandular breast, but even these fibroglandular parenchyma in appearance and color looks different from one breast to another. Another 6 examples, okay? Again, not similar to each other and to the previous one. Another 6 examples. Can you see how it differs? And even within the same breast, we can see some difference while scanning the patient. We might find one part of the breast with thick layer of fibroglandular parenchyma, while others island of parenchyma with intervening or a fatty tissue. Again, look for these examples. This not fat. This is a glandular This is fibroglandular or glandular parenchyma, as well as this one. It is same as this, but this more echogenic than this. Okay, we'll discuss this later. The reason for that. Here, partially involuted breast, the layer of fibroglandular parenchyma become smaller, as in these examples here. Okay, and these completely involuted a fatty breast. Also, look for these fatty breasts. Is also look variable from lady to another. And what about this? Can you tell me what about this type of parenchyma? This one? Do you have any suggestion? This and this type of parenchyma? Okay, so in this example, these are DCIS, see? Seen as non-mass-like lesions, you see? Just part of the parenchyma, this hyperechoic, same as the adjacent fibrotic parenchyma, but there is subtle distortion. Again, here there is some distortion and posterior shadowing. This represents also DCIS, while this shadowing parenchyma in a case of invasive lobular carcinoma. Okay, let us go to microanatomy of the breast. As you know, the breast having about 15 to 20 lobes. These are lobes. You see, each lobes drained by a lactiferous duct that converge toward the nipples, okay, in a radial pattern, as you have seen in these illustrations. And each lobe comprises of or composed of 20 to 40 terminal duct lobular unit or lobules, or lobules. Each lobe, as we said, empties into a lactiferous duct, okay? And then open into the nipple. And the terminal duct lobular unit is the functional unit of the breast. Okay. There is shadow. Did you hear a shadow? Excuse me. May you close your mic, please? There is background noise. Okay. Let us go for the ductal anatomy. The previous lecture, we start talking about the ductal anatomy, in the anatomy, in the discussion of the nipple areolar complex. And we mentioned that we have about 5 to 15 lactiferous duct converging into the nipple and open through it. And just behind the nipples, you see, this here, you can see the convergence of these ducts, and it should not be more than 2 millimeters. And just beyond the nipples, these lactiferous duct demonstrate a focal dilatation. This focal dilatation termed lactiferous sinus, and it is a reservoir of the milk, and it is about 3 millimeters, and sometimes can be palpable and should not be mistaken for lesions under ultrasound. Okay, going further, again, this is the converging lactiferous duct into the nipple, and these are lactiferous sinus, and these are divided and further divided into segmental, subsegmental, you see, terminals, until here the lobule ended into ductules. We can see it further. Here we can see the arborizations of these ductal system into numerous smaller duct from here, large ducts around the nipple into smaller and smaller ducts, okay, going toward the terminal duct lobular unit. Here, this is the main duct, and these are terminal ducts. The terminal ducts, we have extralobar terminal ducts and intralobar terminal ducts. Here we can take an example of a single segmental ducts from the nipple here. As we mentioned before, we call it as a collecting ducts that open into the nipple, and just behind the nipple, this is the lactiferous sinus, the focal dilatation, and the segmental duct then started to divide into subsegmental ducts, and until reach the terminal ducts. These are extralobar terminal ducts. This is extralobar, and inside is intralobar terminal ducts. Here we can see this is a segmental duct, non-dilated or minimally dilated segmental duct, and this is a terminal duct lobular unit, and this is a histopathology image representing a main duct, extralobar terminal duct, and a terminal duct lobular unit. Again, for more explanation, this is the main duct, see, divided into subsegmental ducts. We call it also interlobar ducts, and these subsegmental divided more and more until reach a terminal ducts, and the terminal ducts outside the lobule, we call it extralobular duct, and inside the lobule is intralobular duct. So the extralobular duct join the lobule with the main ductal system. Here, this is histopathology image demonstrate this is the lactiferous duct or a main duct, and here we can see a terminal duct lobular unit with extralobular terminal duct, and this is a lobule with a senescence inside. Okay, regarding the normal ducts, if you want to see the ducts, the best scanning is radial scanning. You see, it's the best technique to visualize the duct, and you can see it as a fluid-filled and echoic tubular structure converging toward the nipple, as you have seen here. It's supposed to be less than 2 millimeters. So this is a normal ducts, but these are abnormal because though are anechoic, but are a little bit dilated. This one is dilated. This is the main duct, and this is a branching duct. Not only dilated, but there is internal echoes, appear as hypoechoic rather than anechoic. Here we can see example of a normal ducts. This is a normal major ducts, but the duct is collapsed. You see, and this, the wall, anterior and posterior wall, the yellow arrow representing this echogenic line represent opposing anterior and posterior wall lining this thin anechoic line representing fluid within the duct, while this is ectatic duct. You see, here, this collapsed duct, we can see the grayish periductal stroma. But this, because it's expanding, the duct compressing the periductal stroma, so no longer sonographically visible, the periductal stroma. These are examples of ductectasia. Variable dilated ducts, most of these examples are anechoic, just a simple ductectasia, while this is a complicated ductectasia. There is an internal echoes. And as you know, ductectasia is almost 50% of women by the age of 50 years having an ectatic duct. Is a common presentation in ultrasound clinic, you see? And most of the time it is just an incidental findings, but sometimes presented with periductal mastitis, as in this example, two examples. In this periductal mastitis, definitely this duct is abnormal with internal material, echogenic material, and periductal edema, you see, and here periductal increased vascularity, hypervascularity. Again, there is periductal edema, ductal wall thickening. The duct wall, it has to be imperceptible. Here there is ductal wall thickening, and here there is periductal vascularity. So Doppler is helpful if it is positive. You see, it can demonstrate periductal vascularity in case of periductal mastitis, and can represent intraductal vascularity in case of intraductal soft tissue lesion, and most of the time represent intraductal papilloma, and less and exceptionally can represent intraductal carcinoma. See, these are the differential diagnoses for intraductal vascular lesion. Commonest is papilloma. but not always the case. We have a false positive, as in the case of milk ejection in a lactating woman. And the ducts, as we mentioned, has to be, the duct have to be echo-lucent or anechoic. Also, are brised and tapered in smooth, stepwise fashion. It becoming progressively narrower in caliber going toward the parenchyma. So any abnormal morphology will make it suspicious. A solitary dilated duct per se is suspicious. If it is solitary, it will be suspicious. And these all having this example have an abnormal suspicious morphology are irregular. Another suspicious findings, intraductal material or intraductal echoes. And this also, there is blunting peripheral edge here, okay, rounded instead of tapering, and intraductal material. In spite of all these, definitely we have to proceed for biopsy. But after biopsy, the result tend to be just a ductectasia with a proteinaceous material. These intraductal lesions are just a proteinaceous material inside the duct. But we have to proceed for biopsy. Okay. Other options, we can do it. We can proceed for galactography in case, especially if the patient having nipple discharge. Okay. This is having intraductal lesion on ultrasound. Excuse me, please. There is background noise. Would you please close your mic? Okay, there is cutoff here on galactography, corresponding to these intraductal lesions. And the same patient have an MRI demonstrate this is T2, representing a duct with a soft tissue within the duct that exhibiting contrast enhancement on post-contrast MRI. Okay, another things to evaluate intraductal lesions, the presence of calcifications. If the intraductal lesions associated with calcifications, definitely it will be suspicious for biopsy and is suspicious for ductal carcinoma in situ. Okay, again, we mentioned the duct has to be smooth and tapered toward the parenchyma. It should be smaller toward the parenchyma. But these two examples, can you see it here? It has a blinded, rounded edge rather than smooth tapering. So these are suspicious. This is anechoic, and this is there is filled with intraductal lesion extending toward the nipple. This is intraductal mass, and this is also a suspicious, having a beaded appearance with intraductal lesions and possible fine bright echoes representing calcifications. These are examples of pure DCIS. Also, the ducts are beaded, tortuous, okay, irregular, and hypoechoic, indicate there is intraductal soft tissue rather than echo-free. Okay, so the ducts are tapered going toward the parenchyma, and these are the branches going toward the terminal ducts, and you can see it through the parenchyma like this. Iso, as we mentioned before, the periductal stroma is iso to the fat, so it will appear as gray, isoechoic to the fat. These are intraparenchymal ducts. These are ductal branches. Here are ducts. ducts along with terminal duct lobular units. You see, but when we see it elongated, this is definitely duct. Okay, this is here, you can see segmental duct with ductal branching and TDLU. These are posterior TDLU and anterior one. And you can see the gray, you see, periductal stroma. The ducts, as we mentioned before, there are variations in the ductal caliber. It can be collapsed or it can be dilated, you see, but it's supposed to be not much or not abnormally dilated. And the epithelial lining of the ducts are hyperechoic. You see, you can see it here, and the anechoic in between. This is thin fluid, this is non-dilated ducts, you see. And again here, the same within the parenchyma. This line represent opposed wall of the ducts. And these small anechoic areas, you see, represent duct. But this duct here, if you can see, this duct, branching duct is irregular and a little bit hypoechoic, not anechoic, due to intraductal soft tissue in a case of ductal carcinoma in situ. Again, you can see here these illustrations, the duct and ductal branching, and you can follow it here. You see the same as these illustrations, and definitely it will appear in a younger lady. This is a 40-year-old, but start to involute and disappear. This is a 50-year-old. The ductal system much less, and much less in these 80 years old, and or almost even disappear completely due to involutions, postmenopausal involutions. This example of our case having definitely, if you look here, these ducts, intraductal system is abnormal, hypoechoic, irregular, enlarged, and this main duct going toward the nipples also abnormal, and the nipple itself is abnormal. In a case of DCIS associated with in a case of Paget disease with underlying DCIS. And as we mentioned before, the cells in a Paget disease inside the ducts can extend along the epithelial line because it is continuous with the skin of the nipple, reaching the nipple, resulting in pagetoid cells. One of the theory. Okay. This here we can see illustrations and or schematic view and ultrasound image of segmental distribution of ductectasia. It can be single duct or can be multiple duct, but whatever, if it's single or multiple, segmental ductectasia is a suspicious ultrasound findings. These are different examples of segmental ductectasia, mild to moderate to severe, anechoic or hypoechoic. All of these are suspicious, can represent fibrocystic disease, but are suspicious for ductal carcinoma in situ or in situ. This is my patients having segmental ductectasia with calcification in a case of high-grade DCIS. These are examples of segmental ductectasia within the parenchyma. You can see this irregular hypoechoic ducts with beaded appearance and soft tissue component, and this associated with calcification, again, soft tissue. All of these represent DCIS, and this example associated with micro invasions. While this this is another example of remarkably dilated intraparenchymal ducts with ductal lesions. This example of mildly dilated duct with intraductal lesion in a 70-year-old biopsy. The needle biopsy was failed, but surgical pathological result demonstrated intraductal papilloma. Okay, let us go to terminal duct lobular unit anatomy. Okay, this illustration for the ductal system. We mentioned that the duct going arborize until reach the lobule and ended into a ductule. Another illustration demonstrating the terminal ducts. Okay, this is the extra lobular terminal duct and this intralobular terminal ducts, and here these are acini or ductule. So this is a lobule formed by these structures, intralobular terminal duct and acini with stroma forming the lobule, along with the extralobular terminal duct together representing the terminal duct lobular unit. And as you know, the terminal duct lobular unit is the functional unit and the histological unit of the breast. This is the factory of the milk, and this is where most of the breast pathology arise, especially breast cancer. Again, a representations of terminal duct lobular unit. See, this is a terminal duct extralobular and intralobular. These are acini, you see, and the dark pink are acini, and the baby pink is intralobular stroma. Altogether, they call it lobule. And as we mentioned before, we have about 15 to 20 lobe, and each lobe contain about 20 to 40 lobule, you see? And within the lobule, there are numerous acini. These acini are also variable, and they mention that around 10 to 100 acini. And in other literature, they mention that it might be up to 200 acini per lobule. Are you following me?
Yes.
Okay. So, again, this is terminal duct. See, this is subsegmental duct or a main duct. Okay, divided into terminal ducts, extralobular terminal duct. Along with the lobule, we said these are lobule. These are lobule. The lobule with extralobular terminal duct together form the terminal duct lobular unit. And the lobule, see, contain intralobular terminal duct, the extension of the extralobular terminal duct, and ended into these blind-ended ductules, okay, where is acini. And this part, the terminal duct lobular unit, is the functional unit of the breast, and why it is important, most of the breast diseases arise in a terminal duct lobular unit. Here within the breast, this is a terminal duct lobular unit, extralobular duct and the lobule. Okay, this is histopath illustration, is histopath image, sorry, demonstrate extralobular terminal duct okay? And a lobule. This is a terminal duct, extralobular terminal duct, a lobule, another lobule, another lobule. These are multiple lobule, okay, seen in this image. Okay, let us go for microscopic anatomy of the terminal duct lobular unit in more details. See, as we mentioned, the terminal duct lobular unit consists of a lobule along with extralobular terminal duct. Okay, this is the extralobular terminal duct, and this is a lobule. The extension of extralobular terminal duct inside the lobule is intralobular terminal duct. Okay, and within the lobule, okay, there are numerous ductules or acini embedded into stroma. And the stroma within the lobule, as we mentioned before, is the loose stroma. It is gray. It is isoechoic to the fat. And extending along the ducts, the periductal stroma is also, look here, even extending into the main ducts. The stroma of the periductal, as we mentioned before, it is gray. It is isoechoic to the fat. Okay? And again, here you can see it in histopath image. This is lobule, extralobular duct, and a main duct. While this image is Stephanos from Stephanos lecture, you see, he presented of a normal terminal duct lobular unit in longitudinal and perpendicular transverse image. This is an ultrasound image of a normal terminal duct lobular unit. Can you see these tiny, more hypoechoic dots within? These represent the acini. And as you know, both epithelial and stroma of terminal duct lobular unit influenced by hormones. Okay. We have seen this image of the ducts, okay, previously. And here, this is the image. These are the duct, okay, fluid-filled ducts, okay, extralobular ducts. And these are acini. This is a lobule. And here we can see these isoechoic or slightly hypo to the fat, sometimes can be slightly hypo to the fat, representing as also here slightly hypo to the fat. These are terminal duct lobular unit along with the duct. These are elongated, representing the duct, and these representing terminal duct lobular unit. Again, here it is more or less iso to the subcutaneous fat. Okay. The terminal duct, the normal terminal duct lobular unit varies in shape and size, and usually measure 1 to 2 millimeter width, and its length about up to 6 millimeter, but can a little bit slightly larger in size than this, up to 6 millimeter. Okay, this is a segmental duct. Here we can see the segmental duct. And these are representing lobule. These represent lobule. If you look here, this row, this is segmental duct parallel to the skin. These are anterior, and these are posterior. So if you look here, more numerous anteriorly, the extralobular terminal duct is longer anteriorly, while the posterior a little bit shorter extraterminal extralobular terminal duct, and the lobule are a little bit smaller. But the largest terminal duct lobular unit is, or the lobule, is the terminal lobule. It is a terminal lobule at the end of the duct. Is a terminal lobule is the largest one. Okay. This is a segmental duct, illustration of segmental duct coming from the nipple, going into the parenchyma till the terminal lobule. You see, this is a terminal lobule. These are the anterior, and here are the posterior. These are too numerous compared to this one. Again, too numerous compared to the posterior one. So that is why you will see at the anterior toward the skin, in the parenchyma, you will see more numerous oval structures compared to the back or posterior part of the breast. Here, these are ultrasound image. You see, as we can see, too numerous oval terminal duct lobular unit in the anterior part of the parenchyma compared to the posterior half. In this example, again, if you look here, if we can divide the parenchyma into two, can you see the anterior compared to the posterior one? Okay, going further to see what is inside the ducts and the lobule. Okay, as you know, the ductolobular system is a bilayered. It consists of two layers. The inner luminal layer is epithelial layer, and the outer basal layer is myoepithelial layer, and the myoepithelial surrounded by the basement membrane. The significance of that, we'll see it here. This is a normal duct, and this filled with abnormal malignant cells, but these cells do not extend beyond the basement membrane in a case of a DCIS. Okay, here the example of the cells contained within the duct lumen does not extend beyond the layer of myoepithelial layer, not breach, intact. But in the other example here, the cells breach, the myoepithelial layer breach, and the cell extend into the adjacent breast tissue. And as you know, the breast tissue, the breast looks like a tree and composed of different tissue, as we mentioned before. And this is result in a heterogeneity of the breast cancer disease, if it is arise from this structure or from that structures. Okay, here we can see a normal duct, hyperplasia, okay, abnormal duct, but still a benign cells. This is borderline atypical ductal hyperplasia going into ductal carcinoma in situ, and then reaching the basement membrane or the myoepithelial layer and is spread into the adjacent breast tissue. This is the progress of the malignant. This is the malignant progress through the ductal or ductolobular epithelium. Okay, let us go for the corresponding ultrasound appearance. Here we can see this is a normal duct following this appearance. This is an abnormal duct. Biopsy revealed atypical ductal hyperplasia. This is abnormal duct. See, biopsy revealed ductal carcinoma in situ. And this is another example of ductal carcinoma in situ, you see? And in the latest examples here, this is biopsy revealed atypical ductal hyperplasia, but surgical specimen revealed invasive ductal carcinoma. So what is the significance of that? There is overlap in ultrasound appearance or in the imaging appearance of these process. And as you know, if you look for this example, we can understand that in the same lesions, we can find all of these. We can find normal hyperplasia, atypical hyperplasia, DCIS, an invasive component. We can find all these together in the same lesions, and that is why if there is imaging suspicious, biopsy is recommended. And if the biopsy result revealed any of these from here, atypical hyperplasia, DCIS, or whatever, or not concordant with the imaging, then surgical biopsy has to be recommended. And even if it is proven to be atypical ductal hyperplasia or something, then they have to excise it. And because first of all, it is a risk considered to be risk for cancer, and it after surgery, it can be upgraded into DCIS or even invasive cancer, as in these examples. And here we can see this is a normal, this is the luminal epithelial, and this is myoepithelial and basement membrane. These all are histopath image, and this is just an illustrations of a normal duct cells. These are examples here of ductal carcinoma in situ. This is examples of invasive ductal carcinoma with the breach in the basement membrane. To me, it is not clear, but Dr. Nadia might comment on this. This is a normal ductule, histopathology image of ductule. Dr. Nadia, do you like to comment on this?
Yes, you have in the first one normal histology is beautiful image. In A, you have the double layer of epithelium,
Yes.
myoepithelium, and the basement membrane. Very obvious.
Yes.
Now in DCIS, you can see you also have in the center the duct is obstructed by necrotic debris. And this is why we call it comido DCIS.
I want to raise the voice. Okay.
That's why we call it comido. Comido refers to necrotic tissue in the center of the of a lesion, because
yes.
it can happen in frank malignancy or
Yeah.
in DCIS.
Yes.
Once you have the tissue is not being supported by enough blood supply, you get necrosis, and it's part of a feature of malignancy.
Yes. But because the basement membrane is intact, that
you
means
call it DCIS.
Still it is contained, still even if there is cells and there is necrosis and all these stuff, but still because it is contained still within the duct or lobule, then this is carcinoma in situ or in situ.
Yes, it is still carcinoma in situ. You can get the necrosis and the calcification, but it's still, as long as the basement membrane is not invaded. And
yes,
and this is the point where we have to do a lot of work in the lab, because once you see DCIS, you have to exclude that one of the ducts that has DCIS, not that a nearby duct is not already invasive, or another site in that duct has not already invaded. That's why we do what we call levels. Levels means that from the same block of tissue from which you did the slide, you do more slides.
Okay, we are going to this point. I will give you a chance to discuss it more. But
Okay.
comment on this image. To me, the breach on the basement membrane is not clear.
No,
Yani
in this,
here it is obvious. This is the bilayer, okay, the luminal and the myoepithelial layer, and this is the basement membrane throughout.
yes.
I can see it, and even in this in the ductule, as in the illustration. And here I can see it, but in this illustration, maybe here, I don't know.
I'm not sure from this image, and I can go to higher ones. And the other thing is, it could be like in the duct that is in the corner. You can see that the tissue is coming very close to this duct on this side. But the thing that you can't see very clear, like in the histology duct, is that the basement membrane is not always that obvious.
Uh-huh.
So in our case, you can do immunohistochemistry and look for the myoepithelial, because in cancer you don't have a myoepithelial layer.
Yeah, it will be breached.
It will be breached, but it's the basement membrane will be breached, but you lose the myoepithelial layer.
Yeah, I mean, what I meant, the myoepithelial layer will be breached, not the basement membrane, even in the cancer.
Yes.
Yeah. If the myoepithelial layer breach,
No,
then
the
the
basement
cells
membrane.
will go out.
The basement membrane.
Outside and infiltrate the adjacent tissue.
You see in yellow, you under invasive cancer, in yellow you have the pathologist indicated that the basement membrane was breached, indicating the basement membrane was breached, indicating invasive nature.
Yeah, that is why I highlighted in yellow, because for me, I couldn't visualize it. So
you have to go higher magnification. And in some cases, it's even, you have to do special stains and immunohistochemistry.
Okay. That is why they mentioned that the pathologist indicated the basement membrane was breached. Okay, thank you, Dr. Nadia. Thank you. And this again, it is yours, but this histopathology image of a normal duct, and these are lobule here. This is our acini, and like a tree, you see. Can you hear me? Because it gave me that internet is unstable. But in this example, it is obviously that the acini are big, enlarged. You see, are enlarged by cancer cells. So here the difference between normal and abnormal. And here I have to mention that the pathology, especially malignancies, arises more from TDLS, TDLUS in almost to 85%, while from the ductal system in 15%. We brought the broccoli, the ductal system simulate the broccoli, and here you can see these representing the main duct or the major ducts, and these are the lobules. And as we mentioned, we have pathology arising here from these main ducts, but most of the pathology arising here. And this is from the, what? You can see this slice of broccoli, you see, longitudinal and transverse. This, you can see this, simulate a lobule. And here you can see this is a duct, and this is extralobular terminal duct, and here these are lobules, same as this histopathology slice. This represent, all these are acini in a lobule, and the outside, this one here, representing the extralobular terminal duct. And as we mentioned before, most of the pathology arising from the terminal duct lobular unit. If you read here, you can see the fibrocystic with all types of fibrocystic changes, fibroadenomas, phylloides, cancers, most of the pathology arising from the terminal duct lobular unit, while only papilloma and ductectasia, Paget disease, and few percent of cancer arising from the major ducts. And some pathology arise from the stroma or fibrofatty stroma. Okay, again, here we can see the pathology arising from different parts, and this image can represent this adenosis from terminal duct lobular unit, fibrocystic, DCIS, epithelial hyperplasia, sclerosing adenosis, all of these arising from terminal duct lobular unit. These examples of dilated terminal duct lobular unit or acini in a case of fibrocystic. This is fibroadenoma, also arising from a terminal duct lobular unit stroma. And here, this is the sclerosing adenosis appearance on a histopathology image. Okay. Let us go for terminal duct lobular unit again and look for this arrow. What does it mean? What is the difference between this lobule and this lobule? The lobule, anterior and posterior, oriented, oblique, or perpendicular to the segmental duct, while the terminal lobule is parallel. So what does it mean? What is the clinical significance of that? Cancer arising in this lobule might present as a parallel lesions, parallel to the skin. While cancer arising here and here, which is these are the most common than this one, that we'll see the cancer is antiparallelly oriented. This is from literature. This is a normal terminal duct lobular unit. This is an abnormal. This is a cancer arising a terminal duct lobular unit oriented non-parallel. And this is our patient from SOBA. You see, this is a segmental duct. This is enlarged, but still smaller anterior lobule, while this terminal lobule, can you see it infiltrated with pathology proven breast cancer? And this, I have to mention that these discussions and this image from Thomas Stefros. Okay, if you look here, these are terminal duct lobular unit. What about this terminal duct lobular unit? It looks disproportionately larger and a little bit deeply hypoechoic, and even this portion here, it looks like anechoic or cystic. So it start to get enlarged and cystic, changes in a terminal duct lobular unit. And these histopathology illustrations correlate a normal terminal duct lobular unit with enlarged terminal duct lobular units. All these are acini, enlarged acini, and these tiny, tiny black dots represent what? Apocrine metaplasia. Okay, so Let us go for, as you have seen here, this is the most representations of these structures is histopathology. And histopathology, when we look to this image, histopathology, we could imagine exactly what does it look like. But this extra-terminal duct lobular unit, and this is a lobule. These are normal. And this one definitely here, the acini cystically dilated. If we look for this one, there are multiple cysts here. Okay, oval structure with multiple cysts, and in between these cysts, we have thin septations. If we look for this illustration here, this represents what? Cystic dilatations of acini. So these are acini within a lobule. Cystic dilatation of acini in a lobule, and this is represent what? This is the wall of the acini, representing what we call it cluster microcyst. Here it is obvious, extralobular. This is a lactiferous duct because these multiple terminal ducts join into subsegmental or interloper lactiferous duct. This is extralobular lactiferous duct, and this is intralobular lactiferous ducts. And these all lobulated structure represent acini within a terminal or within a lobule. Again, this is the image of Thomas Stavros of a normal terminal duct lobular unit in transverse and longitudinal. This is here, you can see the extralobular terminal duct, and this is a lobule with acini, tiny acini seen inside. This is also his image representing a cystic dilatation of acini. You see, these are cystic dilatation forming cluster microcyst. And if you look for inside the wall of these, the wall of acini become hyperechoic, representing the stromal changes, and that is why it become whitish before it was grayish. So together, these stromal changes along with cystic changes forming the what is called fibrocystic changes. And here we can see the extralobular duct. Okay, so here we can see these are obvious examples of cluster microcyst. Straightforward acini, mildly dilated acini, but still I can see the walls of these acini within the microcyst. If you look for this row here, you can see less number of acini, but larger than in the first row. What does it mean? What is happening? You see, or what happened? What happened for this? The wall of acini is either effaced or ruptured. You see, ruptured in between, forming a larger cyst. But still, we can see some of the wall of these acini. Further enlargement, effacement, and rupture result in macro clustered macrocyst. From microcyst to macrocyst, become larger until completely effaced and result in a simple cyst. Okay? Here you can see this example. This is one cyst. For here, smaller, numerous microcyst. Getting less, but larger, and more larger with less septations. So when fibrocystic getting worse, the cystic dilatation of the acini become larger with rupture or effacement of the wall of these acini. And as we mentioned, usually the caliber of acini, suppose, or the caliber of terminal duct lobular unit should not be more than 2 to 3 millimeters. And in these examples here, if you have seen a duct or these tubular structures coming from a cyst, is not a suspicious one. If it is a simple cyst, this is the extralobular terminal duct, because this is a lobule, become unilocular cyst, and this is a terminal duct lobular unit. And most of the time, yeah, it is an straightforward, and we can just manage it so easy, you see, but it has to be anechoic, okay? Each of these cysts within the lobule, it has to be an anechoic cyst with posterior enhancement, and the wall or this septation has to be thin, less than 0.5 millimeter, and no internal echoes and no associated vascularity. Otherwise, it can be complicated or even complex. And we have some problem regarding our less quality machines, non-high resolution machines, you see, so we might find difficulty to resolve the septations of the cyst and might appear to be a hypoechoic lesion rather than a small microcyst, and make it difficult to call it as a benign lesions. Okay. Also, there are other challenges regarding these microcysts. Even in a fibrocystic, just a benign fibrocystic changes, the acinar-cystic changes are not always uniform. If you look for these illustrations, you can see some changes. This is the normal one. You look here, there are changes here, but while the other remain normal, not dilated. Why? Because they said that this depending upon the uneven distribution of estrogen receptors, making the interpretation, this will make interpretation of the cyst as a complex. If you look here, you might find part affected while the other are not, giving apparent thick septations, same as in these examples. You see, all are fibrocystic, but because of some of the acini affected by the hormones and get dilated, while the other are not, due to uneven distribution of estrogen receptors, giving a challenge of a complex rather than just microcystic lesions. Okay. There are other reasons make it more challenging. If there are internal echoes, fluid within these cysts, either proteinaceous fluid or fat or debris or whatever, this is one issue. And if there are epicrine metaplasia, if there is intracystic epicrine metaplasia, will will appear as hypoechoic rather, or echogenic rather than anechoic, and we have a suspicious findings, or there is a malignant lesions can be presenting like this, which is a micropapillary DCIS, but usually less than 1%. Here we can see some examples of a suspicious microcyst. In this case here, this is apocrine metaplasia, a benign process. This is again adenosis complex, you see. And in this example, another example of fibrocystic affecting part of the acini while the others are not, appear as complex rather than just simple microcystic lesions. And here another example of fibrocystic but proliferative types with extensive papillomatosis. And these examples here, we can see cysts and we can see even microcalcifications. You see, in a case of sclerosing adenosis with papillary and apocrine metaplasia. As in the ductal evaluation, here we can use the Doppler, you see, and Doppler can be helpful, but if it is negative, as in the ducts, it will not be helpful. It will be extremely helpful if it is positive, but if it is negative, it is not useful, because there are many reasons. One of these reasons, technical issue. If you firmly compress your probe, it might result in lack of vascularity. When they raise the probe here, you can see intracystic cluster microcyst with intracystic vascularity. Whenever you have vascularity in microcyst, it is a suspicious one. Presence of vascularity make it suspicious, and you have to recommend biopsy. And here we can see different examples of these are fibrocystic. Sorry, I don't know why this coming here. This is fibrous. This is DCIS. These are DCIS. Okay. Here, these are DC, and even this is invasive cancer. While here, these are fibrocystic, and this is a papilloma, or are cluster microcyst. But if you look, are not as typical as the first one we described earlier. Straightforward, we can go for BIRA2, just a simple microcyst. Whenever we have seen some suspicious findings or atypical, we have to proceed for biopsy. And also we can use, apart from Doppler, we can use an elastography. And in this example here of lactation adenoma with the fibrocystic changes, the elastography helped us and giving us the tri-layer typical appearance of fluid content lesions, the blue, green, red signals. This is an examples here. You can see these not typical microcyst. You see, it looks like a microcyst, but not very typical. This is invasive lobular adenocarcinoma. And this example here at the beginning assumed to be a microcyst, and but because it is not very simple, a little bit complicated, they recommend follow-up, and after 6 months presented with significant enlargement in a case of grade 3 invasive ductal carcinoma. Again, here we can see example of invasive lobular carcinoma. This is a microcyst. After 12 months follow-up, these cysts disappear, but there is this area seen here, subtle distortion. Don't say after resolution of the cyst, this might be the residual part. No, this is subtle hypoechoic and distortion. They biopsied and proven to be 4 millimeter invasive lobular carcinoma. And this is lobulated mass on mammography and cluster microcyst on ultrasound. After follow-up, 6 months, demonstrate, although of the same site, but it become more complicated and complex and look at the septum, and it's proven to be invasive cancer. Okay, as you know, there are a lot of changes in a fibrocystic condition. Excuse me, please. Background noise. Okay. In this illustration, you can see a lot of changes in a fibrocystic conditions, and we are going just to have this part of fibrocystic. Look for this normal again, normal Staphylococcus TDLU, okay? And when these TDLUs getting large and large and large and increase in number, look, the number of these are too numerous, become large and large. They join together and make this uniform sheet of isocoic parenchyma to the fat in a case of breast adenosis. See, but we have to be cautious. Not always it presents like that. This is another example. These are my patients. This is another patient of mine. You see, presented with a tumor mass, and it was adenosis, also tumor adenosis, you see, but this example looks more or less the same, but these TDLUs enlarged with cancer is not, and this is my patients. Again, this is adenosis. So we have to be cautious. We cannot always say confidently, this is an adenosis and colostomy. So what is adenosis? As you know, it is a benign proliferative process. Affect mainly the lobular or the acinar component of the parenchyma. During puberty, the lobular proliferations or differentiation is seen first at the peripheral region of the breast and extend centrally. And that is what is the clinical significance of that? Any suggestion? What is the clinical significance? Any suggestion of that? Okay. They are commonly presented with upper outer quadrant tender breast swelling. Any suggestion for this abnormality or this finding? Do you have any suggestion for that? Can you see the image now? The upper outer quadrant. She has more pain in the right breast compared to the left. This is adenosis. You see, this is very common presentations. Young ladies, okay, presented with tender swelling in the upper outer breast due to physiological adenosis. What is the other clinical significance of adenosis or of this type of parenchyma being more peripheral, especially upper outer quadrant, and then proliferate centrally? The presence of large amount of glandular tissue in the upper outer quadrant and the latest part of the breast to be involuted make it what? The commonest location of breast cancer.
The common spot.
Almost half of the breast cancer present in the upper outer quadrant. It's okay. Again, the anterior terminal ducts, the anterior terminal lobular units are more prominent than the posterior. Okay. Even the pathology, see, since are the presence of terminal duct lobular unit more anteriorly, so the pathology is also appear more anteriorly than in the posterior breast. So what do you see here? You can see some enlargement and some changes in the terminal duct lobular unit. What do you suggest the diagnosis of this? Do you have any suggestion? Okay, this was fibrocystic, while this one, it was a DCIS. Okay, another DCIS here, also anterior. Can you see here this anterior mammary fascia subcutaneous? You have seen it anterior, and the remaining posterior, this thick parenchyma posterior to that. Another changes here seen anteriorly in a case of invasive lobular carcinoma. What do we call these? These are not masses, but are non-mass like lesion, similar to non-mass like enhancement seen on MRI. Is it a gray glandular tissue? It is gray glandular tissue or pathology? It is just a gray glandular tissue, or there is pathology in these structures. Can you consider it normal? In other way, can you consider this ultrasound normal, or you call it as, or you rate it as a pathology?
It's a pathology is abnormal.
Abnormal.
Yes.
What is the abnormality? Okay.
Barely aberrant is upper as a upper one as a left.
Yes, we can see here deeply hypoechoic enlarged terminal duct lobular units and some of the ducts. You see, this is a fibrocystic. This my patient, it was fibrocystic patients. And again, look for this. This is definitely abnormal. This we call it non-mass like feature or non-mass like abnormality, ultrasound abnormality, breast ultrasound abnormality. And we can describe it. Here it looks like a ductal architecture. And these are patchy, hypoechoic, or these both examples are non-specific features of DCIS. Again, look for these here, it is duct-like structures, okay? This is grade 2 DCIS. And again, these are all example of DCIS. You might say, yes, here I can say DCIS, but even this is a DCIS. We have a lot of patients like that. You see, they have shadowing parenchyma, hypoechoic parenchyma, multiple patchy like that. And some of these cases we reported as an abnormal breast for clinical correlation and biopsy. But to be honest, some of our colleagues, they don't accept our reports. That is why I invite my colleagues to these lectures to show them, we have even some of these cases, or most of non-mass like breast lesions are sometimes are asymptomatic, and sometimes can be discovered in a screening study, or sometimes can be symptomatic but not palpable, not necessarily to be palpable, but at the end represent pathology. And not only pathology, most of the cases represent DCIS or lobular invasive cancer.
Does this
Rarely represent fibrocystic changes.
Excuse me, Rabab, does such lesions, non-mass lesion, affect the TNM staging system? Regarding the T size, it means a lot in the staging system. So this lesion may not.
If it represents invasive lobular carcinoma, it will not affect it. If it represents a high-grade ductal carcinoma inside,
I mean to be a lesion, a well-defined lesion with diameters to
No. At the end, I will measure for you the span. I will measure for you the span of this lesion. I used to be honest, since long time. I tried to correlate these findings. I used to see this abnormality, not typical of breast mass, but there are parenchymal changes, definite parenchymal changes. I was thinking how to describe. I start to describe as I have seen it. Yeah, it is a hypocoic with distortion, without distortion. There is some associated calcification, no calcification. There is there is edema, no edema, like that. Parenchymal. I sometimes I describe it as just parenchymal, large area, and I used to measure the area from here to here. Okay, and by location and everything. At the end, I start to think about MRI. These and some of those patients, you see, I have done for them MRI, and I found correlate non-mass-like enhancement. I said, why not to describe this lesion as non-mass-like enhancement, as non-mass-like lesions? Okay, same as on MRI. And I start to put in my report, you see, non-mass-like. Just recently, in the literature, they start to describe, you see, this area as non-mass-like lesions. Okay, and just in the current editions, updated editions, not yet seen, not yet appear, they recommend in the BIRAT new editions, they are going to add these non-mass ultrasound findings in the BIRAT lexicons. You see, just this year, 2000, last year, I think, but it didn't appear. I didn't see it yet.
Rabab,
yes,
Nadia speaking. What in practice, if you reported something like this, what would be the yani you found an abnormality which you think is DCIS at least. In that case, would the lady come back in 3 months? Would you have to convince the physician or the surgeon to do something? Because you located the mass, it can be biopsy.
Excuse me, Dr. Nadia, your voice is not clear. I couldn't recognize what you have said.
If you found such a lesion in practice, what was the procedure? What did you do? Was the patient seen again in 3 months? Was the lesion biopsied under guidance? What used to be practice?
Okay, previously, you see, I used to either recommend, it depends on how it's suspicious. You see, sometimes it's subtle, the suspicious findings are subtle. Sometimes the suspicious findings are obvious. In spite, it is not a real mass. It is a lesion, it is an abnormality, but it is not a real mass. You see, it is not a discernible mass, but there is parenchymal, definitely there is parenchymal abnormality. Okay?
Yeah.
It depends. I used to either recommend directly biopsy or proceed for MRI or recommend follow-up.
Okay.
See? And I have some of these proven to be invasive cancer.
Not even not DCIS, but cancer.
Invasive lobular. I have recently, last year, at the beginning of 2003, before the war, I have one patient, young lady, presented with this infiltrative process. Just the whole parenchyma is hypoechoic, distorted, you see, and hypervascular, okay? And with even skin thickening, without any single mass. And it was suspicious. I recommend MRI and biopsy. MRI just for the staging of, to me, it was by RAT5. It was by RAT5 and proven to be lobular carcinoma. And even that lady, she had cross midline lymphangiectatic spread to the other breast without a single mass.
So she needed bilateral mastectomy at least.
She start neoadjuvant chemotherapy, and I don't know what happened to her after that, because everybody leave or left the Sudan.
Yeah, everything went in. But if like the scenario now, you don't need a mass. This is especially in lobular carcinoma, you don't need a mass, and if you have DCIS, you don't need a mass.
No, what we can say, not all breast cancer presenting typically as a breast mass. As a mass.
Yeah.
You see, especially we even invasive ductal might present as non-mass like lesion. But most of the non-mass breast lesion, okay, are either lobular invasive cancer or ductal carcinoma.
Yeah.
Okay. You got my point.
Yeah, because this is what we see in pathology. The thing is, over the years, we started getting earlier and earlier lesions. And sometimes the lesion is very well circumscribed and we don't even find satellite lesions around it. Sometimes the more blocks you take around the tumor, the more tinier, smaller lesions, satellites you find. So it's multifocal. And then accordingly, we report it as multifocal.
Okay. Let us go. We'll discuss, inshallah, what you have said.
Okay, tamam.
Okay. Can you see these changes here? Again, there is no mass here. None of these 6 examples demonstrate a single mass, but there are definitely these abnormal parenchymal changes. This is non-mass like parenchymal changes with distortion, and here with calcification. This, for example, with calcification. Here with shadowing and distortion, and this example, duct-like or ductal architecture. All these are ductal carcinoma in situ, and even some of which are high grades, ductal carcinoma in situ. You see? And I'll tell you something. Presence of calcification, it doesn't mean early detection. It doesn't mean present calcification. Usually calcification occur late. You see? So, even late presentation still can be non-mass like breast lesions. Okay, let us go for the new classification of breast cancer. As we know, breast cancer is heterogeneous. And the new approach to breast cancer terminology and classification of breast cancer according to their anatomic site of origin. They have a big prognostic difference between these types of cancer, and determination of apparent site of tumor origin using imaging biomarkers is an innovative approach to understanding breast cancer. the new classification of this cancer, including both invasive and in situ carcinoma. Okay, and they mentioned that the breast cancer or the adenocarcinoma arises from 3 separate fibroglandular tissue components, resulting in 3 subgroups of adenocarcinoma, which are significantly or distinctly different clinically, histopathologically, imaging-wise, and or imaging presentation, and significant difference in long-term outcomes, including AAB, okay, acinar adenocarcinoma of the breast, which arise from the terminal duct lobular unit and represent 75%. The in situ component of these lesions supposed not to label as DCIS because it is not arising in a duct. You see, they call it as CIS, carcinoma in situ, because arising from the acini, not from a duct. And this group has a better prognosis. Usually, the in situ carcinoma represent grade 1 and 2, or generally, even the invasive, represent usually grade 1 and 2, okay? And usually unifocal in up to 40%, but still it can be multifocal or can be diffuse as in a sick lobe syndrome. So it can represent a sick lobe syndrome. The other subgroup is ductal adenocarcinoma of the breast. So cancer can arise in a major duct, major lactiferous duct, and this represents about 20%. And this also can be in situ component or early in situ, okay? And here we can call it as DCIS because it arises in a duct. And usually this represents grade 3 or high grade component, high grade nuclear DCIS, because it is rarely discovered early, usually presenting with casting linear branching calcification, and the calcification, it will develop late, often discovered when involving the whole lobe, segmental or diffuse, as in sick lobe syndrome. But maybe a duct-forming invasive cancer, a theory of new ductogenesis, as you described just before, Dr. Nadia. We are going to discuss it more, this area of new ductogenesis, and can be presented or usually presented late with lymphadenopathy and sometimes metastasis. The third subgroup of adenocarcinoma is a breast cancer arise from the stem cells in the mesenchyme, okay? And term breast cancer of mesenchymal origin, BCOM. And this represents about 5 to 8%. And due to transition or transformation of mesenchyme into the stem cells in the mesenchyme transformed into epithelial cells and result in a cancer. The AAB, as we mentioned, that the in situ of which called CIS, not DCIS, CIS. You see, it arises into lobule. You see here, arise into lobule. Most of the time, or 40%, it is unifocal. it has a better prognosis, especially if it is small. You see, unifocal is small, it has good prognosis up to 93% or something. You see, a long-term prognosis. But it can be multiple or multifocal. You see, it can spread. If you look here, this is large. It might be arise in this lobule and then spread to cancerize the ducts and extend into another lobule to cancerize and make it as a multifocal. But still, it can arise in all these together at the same or at once or simultaneously, representing the sick lobe syndrome. And usually this represent or present as nuclear grade 1 and 2, not 3. Here we can see these dilated acini due to cancer arising within. And as they mentioned that this is the most common location to cancer arise in these locations here of the terminal duct lobular unit. And here, this is the corresponding histopathology. And since it is in situ carcinoma, it's supposed to be contained within the terminal duct or within the acini. Okay. Here we can see these enlarged. This is normal terminal duct lobular unit and this lobule, and this is definitely enlarged acini with the cancer, and this is grade 1, you see, CIS on ultrasound, and this is grade 2 CIS. We can see here these acini distended with cancer. Again, the imaging features of cancer or imaging biomarker. According to Stavros, what does nuclear grades affect on or effects on acinar or ductal size mean for ultrasound visualizations? He said that there are definitely, you can explain it more than me, Dr. Nadia, this part. The duct or the acini, it will be distended with either with tumor cells within the lumen, with necrosis and fluid within the lumen, periductal lymphocytic reaction, and periductal desmoplastic reactions.
Yes.
Regarding the low grade, usually we found 1 and 2. Yes?
Yes.
Low and intermediate grade. But the high grade, usually there is periductal lymphocytic reaction and periductal desmoplastic reaction. And since we have all 4 components in high nuclear grade or grade 3, then the ductal or acinal distension, it will be much more than in the non-high grades.
Yes.
And this explains the visualization on ultrasound. The more the visualized on ultrasound, the higher the grade. You see?
Mm-hmm.
Since the high grade are significantly distended, so we could visualize on ultrasound. And on intermediate grade or low grade, it might be visualized because the enlargement is a little bit less than in high grade. He mentioned that the high grade can be enlarged compared to the normal by factor of 4 to 10, while the intermediate grade, it will increase by factor 2 or 4. But the low grade, usually or frequently does not significantly enlarge the ducts or lobule enough to be visualized on ultrasound. So when we describe suspicious ductal carcinoma in situ or whatever, or suspicious lesion on ultrasound proven to be ductal carcinoma in situ or CIS, then it will be from intermediate to high grade rather than to be a low grade. And he advised a radiologist to try to identify a normal duct within the field of view so as to compare it with the duct or terminal duct lobular unit of interest. Okay? This here, there is an ultrasound examples of branching, casting calcifications. This is high-grade DCIS. Even there is no underlying parenchymal lesion, only presenting with a calcification. But it is a high grade because we could appreciate the calcification very obviously on this ultrasound. So the imaging features of breast cancer or imaging biomarker, okay, of DCIS include linearly or segmentally distributed calcification on mammography, or even can be visualized on ultrasound as we have seen in this example. But more visualized on ultrasound is non-mass like lesion, or sometimes we can see a mass. On MRI, most of the non-mass like enhancement representing the CIS or CIS. Okay? And the imaging features have been shown to reflect the biological heterogeneity of the DCIS lesions. And the recent studies indicate MRI may identify a greater fraction of high-grade lesions than mammography. Okay, here we can see in this table, ultrasound, you see, along with mammography, can detect high-grade DCIS. In non-high-grade DCIS, since not associated with, might not be associated with calcifications, most of the time presenting as a mass. When it will be like that, it will only be detected by ultrasound, or it might be only detected by an ultrasound. Here we can see examples of CIS. These are dilated acini with calcification or Samoma's bodies seen within, seen on mammography as this group of calcifications. You see? In a case of grade 1 CIS. And this is ultrasound lesions. This is normal terminal duct lobular unit, but this you can see here not look like these acini, a little bit enlarged due to multiple or multifocal CIS. Again, we can correlate with broccoli here, you see. Another examples here, this is normal acini in a lobule, and this is a dilated acini in CIS. This is a dilated and distorted, vertically oriented in tubular cancer. Another example here, and this is a computer simulations image of terminal duct lobular unit representing a grade 1 and grade 2 CIS. Okay, let us go for again we are talking about adenocarcinoma, acinar adenocarcinoma of the breast. And here we can see this is a grade 1. You see, CIS with Samoma's bodies and amorphous calcification. Definitely, it will be presenting well on mammography, and their correlation, most of their correlation was with mammography, but I tried to bring some of the examples of ultrasound because our lectures is ultrasound anatomy or sonographic anatomy. That is why I did not bring the mammographic images. I correlated with ultrasound images. This is amorphous calcification on ultrasound, you see, representing grade 1 ABBA or in situ CIS, okay? Usually presenting as amorphous calcification. Pleomorphic calcification or coarse heterogeneous calcification usually seen in grade 2 CIS. As in these examples here, this is a histopath and this is ultrasound representing pleomorphic calcifications. You see, the pleomorphic, the grade 2 presenting with either coarse heterogeneous or pleomorphic. And we used to discuss that things with our colleagues regarding, I have one case before in Soba hospitals, and the patient have a suspicious findings in one breast, and the other breast she has just a small group of amorphous calcifications, you see, and they were concentrated on that side, the left side, while to me the suspicion was on the right side more, the lesion what I have seen, and at the end advise to follow that small group of amorphous calcification because it can be, yes, it can be CIS. At the end, it is grade 1, or it can be even a benign, like a Becrine metaplasia or something like that. But the other side, it was a suspicious one, and it was proven to be a papillary carcinoma, the right one. And I don't know what regarding the other one, they recommend for her a follow-up, and definitely after the war, nobody knows what happened. Okay. So as we mentioned before, regarding CIS or acinar adenocarcinoma in situ, usually it will be grade 1 or grade 2. See? If it is grade 3, it will be ductal. It will not be acinar. Invasive ABBA also have low grade and usually present as speculated or oval or circular lesions, as you have seen here. This is speculated in histopath, and these echogenic lines represent speculation on ultrasound, and this is a microlobulated mass, you see, corresponding to this. This is most likely representing invasive AAB. They said that there is in situ an invasive cancer currently termed as ductal carcinoma in situ, an invasive ductal carcinoma, and which are arising from the terminal duct lobular unit, and they consider it as misnomer. Okay, take this point, Dr. Nadia, and at the end, you can discuss and you can tell us your opinion regarding this issue. Okay, let us go to the second subtype or second subgroup, which is DABs, ductal adenocarcinoma, okay, of the breast, the cancer arising in a major duct, not from the terminal duct lobular unit, in a major duct, from interlobar or subsegmental, segmental, and go forth, not from the terminal duct. Ductal carcinoma in situ, here, as we mentioned, is a heterogeneous group of epithelial proliferation confined within lactiferous duct, and nearly always present in asymptomatic women, most of the time detected on screening mammography as a calcifications. and it can extend within the ducts, okay, to other ducts, or can extend into the terminal duct and into the lobular unit. So if we have seen a lesion within a terminal duct, lobular unit, and a major duct, it can arise in a terminal duct and extend into the main duct, or the reverse, or can start simultaneously in both. So DCIS is associated with more dilatation of the duct, as we previously mentioned, because the 4 component or pathological component are included in case of DCIS, and that is why it is aggressive and it has a higher nuclear grades, and sometimes even ductal carcinoma in situ associated with a neovascularity. Okay, corresponding diagnostic criteria are given and focus on linear extension or dilatation of duct in all images. Here, this is obviously significantly dilated ducts with foci of calcifications, okay? And this is also non-mass-like, you see, lesion with calcification representing ducts, and this is also ductal architectures with increased vascularity and foci of calcification, all representing high-grade ductal carcinoma in situ. Okay, it can be invasive cancer, and in case of invasive cancer, also it arises in a major lactiferous duct and is associated with the neoductogenesis. You see, the invasive usually associated with the phenomena of neoduct formation, what is called neoductogenesis. And it is also of high grades, and it has a poor outcome, you see, and also presenting with significantly dilated ducts on mammography. You can see here casting calcification, but look for this numerosity. It is disproportionate with the number of ducts. We cannot find numerous ducts adjacently like this, but this due to the phenomena of neoductogenesis. You see, duct-like, they form duct-like structures, which is disorganized, as we have seen it in these examples. Here we can see this is a duct, a normal, and the acini, you see, and here we can see abnormal duct with normal acini. That means cancer arises in a duct, you see, with the adjacent terminal duct lobular unit free of cancer. The third examples, or the third subgroup, is the breast. The breast cancer arise in of mesenchymal origin, okay? And as we mentioned before, there is transformations of stem cells of the mesenchyme into an epithelial cells that become cancerous, and it represents 5 to 8. And these, they mentioned that corresponding or representing the diffusely infiltrating lobular carcinoma. See, and it has the features deviating considerably from the features of breast cancer originating from the terminal duct lobular unit. It has a mesenchymal features because it's associated with a lot of fibrotic changes. See, not the solid part of lobular carcinoma that presenting as a mass. You see, the diffuse infiltrating lobular carcinoma, they found that, or they suggest that to represent this group. And usually it presents as a palpable thickening of the breast, and it is extensive at the time of the diagnosis, difficult to be detected clinically or mammographically. Okay, and the fatality rate exceeds 30 to 40%. So also the prognosis is poor as DAB, not as good as AAB. And this breast cancer subtype characterized by, as we mentioned, excessive amount of fibrous connective tissue. That is why they claim it to mesenchymal origins, okay? And it has specific clinical, mammographic, and histopathological findings. These features, yes, they mentioned that this large amount of fibrous connective tissue led them propose that it is of mesenchymal origins. Here you can see on mammography, you see the architectural distortion with asymmetry, the diffuse process, diffuse involvement, and here can you see it on ultrasound presenting as non-mass-like lesions with shadowing, not as a mass lesions. Again, here you can see it. I cannot comment on histopath. I will leave it for you, Dr. Nadia. But if you can see here, the excessive amount of fibrotic effect. Here also, look for the fibrosis and the corresponding ultrasound, this excessive posterior shadowing in the parenchyma, diffuse area of non-mass like lesions with posterior enhanced posterior shadowing, reflecting the underlying fibrosis which absorb the sounds. Okay. Multiple ipsilateral malignancy. Here, this is my patient. She has multifocal lesions. Previously, there are many descriptions for multifocal, multicentric, multifocal lesions present within multiple lesions present within the same quadrant with 2 centimeter distance between the malignant foci or malignant multiple lesions with maybe in the same adjacent quadrant, but with a space of 5 centimeter. If it is in different quadrants, multicentric, but the recent definitions regarding both multifocal, multicentric, they collectively refer to as multiple ipsilateral breast cancer. See, just multiple ipsilateral breast cancer, MIBC. See, here we can see this is the largest terminal duct lobular unit. And we can see here all these segments involved. It might be first arise here and then cancerize the duct and other lobule. Or it might be arise in the duct and then cancerize this lobule. Or it might arise at all these points at once, simultaneous. And then in this case represent lobar sick lobe syndrome. So what is the sick lobe syndrome? Sick lobe syndrome is the cancer arising as simultaneously within the whole segment or the whole lobe. Okay? And they mentioned that fundamentally the breast cancer is a lobar disease. And in the vast majority of cases, it is confined to the structures of a single sick lobe at early stage. And due to the distribution of cells within the vulnerable genetic alterations within the same ductal tree, multiple tumor foci may originate simultaneously, synchronously from the epithelial cell within the single lobes of the breast and represent sick lobe syndrome. If it arises in one segment or in one lobe, we call it multifocal. If the same process involves multiple segments, then we call it, at the same time, we call it multicentric. Okay, so here we can see, this is example of the multifocal ductal carcinoma in situ. You can see here the duct significantly dilated at this point, and here less dilated. Definitely here we'll find what? Grade, nuclear grade 3 with this maximum dilatation. Here, this is the illustration, demonstrate DCIS here. You see, then it can spread within the duct. It can spread this way. You see, it can just stay and enlarge, giving a mass. So it can present as a mass, or it can present as a ductal-like, okay, as we have seen in the previous examples. This is my patients having DCIS extending into the nipple, giving a budget disease. If we look for this wax injection into a cadaveric duct, can you see here the lobes? And there is no anatomical boundaries, very obvious anatomic. We can see some overlap, as in these illustrations of a ductal system. You can see overlap between the duct. So it is not like in these illustrations, straightforward, the duct like that. Ducts or ductal system like tree. You see, it is like, it is a tree-like structures. It is a network of ducts and lobules. You see, join together to form a central, like the tree here. Join together, okay, to form a central duct going toward the nipple. If you compare this ductal system, can you see the ductal system here and overlap between it in a histopathology? This is the breast. This is the real breast histopathology. Compare it with this image of a plant and compare it with this plant, this tree. Look for this. You see the ducts going like this. It arborize, okay, and for a short distance behind the nipple. Look here, short distance, then start to arborize into segmental and subsegmental, okay, terminating into the extralobar and intralobar ductules. Are tortuous. These ducts are tortuous, varying in size, intertwining, okay, are intertwined, just like this branch of the tree. Look how are interdigitating. Look for this one. This is duct, this is duct, this is duct, this is duct, you see, and this duct. Same as this here. Look for the duct and their orientation. So if we have cancer here, it can go posteriorly and at the same moment can go anteriorly, can go to the right and can go to the left. If I have cancer here, you see, it can go through this duct to that level and can go to this to the right, can go here to the left. So I have like these trees, you see, these major ducts, and each duct has segmental and subsegmental ducts. This duct and this, look for the branching of this tree, okay, overlap with branches of this tree, and the same in the broccoli. So this can explain, you see, the distribution, okay, and extensions of the cancer within the breast through the ductal system. Because definitely there are no boundaries and there is overlapping of these ductal system. So a single ductal system can extend over a wide area of the breast. And there is no true anatomical line like in the lung. You see, the lung, there are segments and there are boundaries between these segments. But in the breast, we have no these boundaries. So that is why you can, with single duct, you can find in upper outer quadrant a foci and extend to the upper inner quadrant or into upper lower inner quadrant. You see? Okay. What is this?
Here.
What is this structure represent? Represent what? We complete our discussion by this ductal interdigitating ductal system. Let us just see what is this. What does represent this illustration? Okay.
Lobule.
Terminal duct lobular unit.
No.
Which one? So here?
Yes.
What is this?
Terminal duct lobular unit.
Okay, and this? And what is the difference between the two?
Also terminal duct lobular unit.
Okay, look for the structures of this, and let me go back to the previous one. Look for the labeling. Okay? Okay. What about this? Are both the same? Is it the same as that one?
No, in this illustration, bounding the cells of the terminal of the duct and acini like this. The other way.
No, there is one structure missing between the two. Make one structure represent something and the other one represent other structure. There is one structure only missing in one of these. Here we start from
intralobular. It is
intralobular terminal duct, and these are ductules and acini. So this represents no extralobular terminal duct.
Yeah.
Since there is no extralobular terminal duct, this is not a terminal duct lobular unit. There is one part is missing. So this is a lobule.
Lobule, just
lobule. Yes.
This is lobule, intraterminal duct lobular unit, ductules and acini. This is a lobule. While this lobule with extralobular terminal duct together forming a terminal duct lobular unit. Okay, so in summary, according to Stavros, the breast tissue on ultrasound is not only fibroglandular tissue, and the fat lobule are not the breast lobules. Unlike in mammography, many more structures can be seen on ultrasound, as we described. Although fat is often highly echogenic in other parts of the body, it is the least echogenic tissue within the breast and appear relatively hypoechoic to the fibroglandular parenchyma, but actually it is intermediate gray echogenicity, and it is our reference for other structures and lesions. Echogenicity refer to the echogenicity of the fat, and usually we try to adjust it as intermediate gray, okay, and to refer other structure to its echogenicity. Some structures are hyperechoic, like what? Like compact stroma, very
Classification.
like compact stroma, Cooper ligament, okay, and mammary fascia, and interlobular stroma, that giving the brightness of fibroglandular tissue, while intralobular and periductal are gray. These are oval gray structures seen within the fibroglandular, giving this the heterogeneity, alternating hyper and intermediate or relatively hypoechoic. Okay? And this combination of structures giving the fibroglandular parenchyma the heterogeneous appearance. Deep understanding of sonographic anatomy gives opportunity for breast imaging radiologists to do a better job. Studying the complex underlying microscopic breast structures in which changes take place is important for understanding of the pathologic process that occur, which reduce interpretation and helps in detection and characterizing small breast cancer, staging breast cancer within the breast, and minimize the need for unnecessary biopsy of normal or benign lesions. Breast cancer arises from three separate parts of fibroglandular component: AAB or adenocarcinoma, acinar adenocarcinoma of the breast, DAB or ductal adenocarcinoma of the breast, and BCMO or breast cancer of mesenchymal origin. They have due to transformation of stem cell of mesenchyme into epithelial structures. They have distinctly different clinical histopathological imaging presentation and significantly different long-term outcome. They mention that small ABBA, less than 2 centimeter, causes it have cases it have a 95% long-term survival. You see, unlike DABs of the same size. I think they mentioned that the survival or the outcome is about 60 plus percentage. There are opportunities for breast imaging radiologists to assist the oncology community. The ability of imaging biomarker to determine the site of tumor origin and serve as a prognostic indicator emphasizes the increasingly crucial role of breast imaging in interdisciplinary communication and helps optimize treatment decision. Breast imaging features or imaging biomarkers provide a comprehensive overview of the entire breast, reflecting the underlying pathological process, histopathological 3D histopathological images, and provide the pathologist with additional diagnostic informations. Classical anatomy and histology studies have provided the fundamental basis for the understanding of the distribution of multiple ipsilateral breast cancer. Multiple ipsilateral breast cancer, multifocal, multicentric, which has an impact on the role of surgical treatment of multiple ipsilateral breast cancer, often involving the whole lobe, what is called sick lobe syndrome. And thank you very much for your attention, and I hope it was beneficial, and I'm sorry for long time.
No, it was not too long.
I hope يعني.
Thank you, Rabab. Thank you for
Thank
your
Oh, no, thanks.
very nice talk.
Thank you very much.
I'm waiting for your discussion and your comments or questions
Yes,
or anything.
Yes, Rabab, if you give me a chance, I want to ask some question for you. How far?
Definitely.
How far the non-mass lesion can affect, technically, from the theoretical point of view, the insertion of clips for those who are going to undergo a neoadjuvant therapy. So how far do you think this non-mass lesion can affect the insertion of clips from a radiological point of view as technical for you?
Okay, may you explain your question a little bit? You mean regarding its size, being large size, or what do you mean exactly?
I mean, it is not circumscribed size. So do you find any difficulty, or you have any idea about difficulties in insertion of clips by your colleagues, or do you report any technical difficulties for
I
this
think
type of lesion?
I'm not interventionalist. I'm not doing breast intervention, but
Uh-huh.
to my knowledge, there is no difficulties. You see, they might I have no experience regarding this issue, but at the end, since it is suspicious or proven to be malignant, they can introduce, you see, they can introduce a clip or more than one clip from at the periphery of the lesions, okay, or at the maximum area of suspicion. But if you want if you want this clip for post neoadjuvant surgery, then in this case it's better to put it at the margin. At the margin, this is my opinion. You see, I'm trying to imagine if I have a mass, I know that I can put the clip at the center of the mass, and I know the measurement of the mass. But regarding this non-mass life, and usually large, taking large area, I can put two clips at the margin of these lesions from one side to the other sides. So I know that within this area of the clip, it was the malignant process. If you want to take it like that. This is from, I have no idea, I have no experience. I did not read it before. I did not read about it before, but from my opinion, I'm trying to imagine. Just from what I know about these lesions, it can be like that.
Thank you, Rabab. Thank you very much.
No thanks for my duty. Dr. Nadia, would you like to add any things regarding these new classifications?
Honestly, Rabab, to me, it is a new classification. I have not heard of it before, and we are not using something like that. Until last year, when I was working, we used to use the
old.
Yeah.
Yeah, this is. Yeah, it is.
And
yeah.
But what I know, which we didn't do it in Khartoum, but internationally, people are now doing immunohistochemistry and then doing the classification and doing nuclear, because they are shifting more to the prognostic classification. So actually the classification.
Your voice, sorry, Nadia, your voice is interrupted.
Yeah, you know, what actually we were trying to do is go on and do the classification that is based on prognosis, because usually for patients, it was not very useful to have ductal and lobular only.
Yes.
Now, it is the prognosis and how to treat the patient going to more personalized, and we have a different classification that was based on immunohistochemistry and molecular studies.
You mean from biological point of view, Dr.
Yes.
Nadia?
Yes.
Yes, that is why I agree with you. And this new classification, you see, based on anatomical sites, they suggest the same idea.
Yes.
That it has the same idea regarding the prognosis. They have mentioned that previously, the classification is lobular, ductal, and so forth, not regarding their based on their origin.
Yes.
Okay, and they found that the cancer arising from terminal duct lobular unit has a good prognosis. Okay, significantly good outcome compared to the cancer arising from the major duct. And as you mentioned before, you might find, you see, sometimes the tumor extend from the duct into arising in a duct and extend into lobule, or the vice, the reverse, the other way around, or the other way around. Okay, and sometimes you might find it difficult. Is it arising from here and go to there, or the reverse? Yes. That is why now they are trying to make use of radiology along with the pathology to help each other to find the cancer is rising from the duct and going to lobule or the reverse, because the outcome is different.
Yeah.
And this should be discussed in multidisciplinary or interdisciplinary communications or meetings, okay, to reach the consensus or optimized treatment for the patient, and to know the prognosis of the patients from the beginning.
Yeah. I'm still thinking of the situation in Sudan, the way we left it 1 year ago. It is very difficult and expensive to put in immunohistochemistry, let alone nuclear, and to keep it up. The thing is to keep it up and keep the standard. But for the diagnosis of the patient, as anyway, and for all other diseases as well, and patients, we need radiology and ultrasonography. So it is available, and it is something that even the ministry understands and needs to strive, because we needed to convince the ministry of the importance of immunohistochemistry. So until now, it is really difficult. And as you know, most of the immunohistochemistry is in the private practice. Mm-hmm. So this new classification is, to me, very interesting, because it is based on radiology, of course, with histopathology, but it's on radiology, and radiology is available. I know it is not as available as you would love it.
Not only it is a correlation. It is a combination or correlation, pathology, radiology, parallel, going together.
Exactly.
They are trying to correlate the mammographic features, okay, with histopathology features, okay,
and this prognosis.
Yeah, and but this is their study. What is written in the literature? Stavros is a radiologist interested on ultrasound, and he tried to correlate these findings with ultrasound, but really his images are not available in the literature, only in his lectures.
Okay.
That is when I have taken a shortcut from I try to take a photocopy from his lectures, and I have mentioned that this is Stavros
Stavros.
image.
Yeah.
Stavros, yeah, because his image, his ultrasound are from his own
Lectures.
lectures, and his patient.
Yeah, okay, from his practice.
His practice, his practice. He's taking the image from his practice, not available in the literature. So that is why I could not use all these images. I have taken one of the images, and I have mentioned in my lecture, this is Stavros image. And even I have taken like that. I have taken a photo, you see, with my mobile from the computer, and the image, the quality of the image, it become less than the real
but it's
one.
very interesting, and some of the photos of histology photos, they are actually three-dimensional histology photos. These are not ones that we have in the lab, of course.
Yes, so, it is. The histology from the literature. The histology.
So these are special ones. The ones you do for research.
Yeah, they brought, you see, they brought the images of mammography as well as the histopathology, but they didn't mention a lot about ultrasound. They did not mention, you see, a lot about
because they are using a lot of
the majority. The basic study was between mammography findings and histopathology findings. Why? Because they depend on screening mammography findings.
Yes.
You see, but Stavros mainly interested on ultrasound, and he correlates these findings with ultrasound and with MRI.
Yeah.
And I have interest even to dive a bit more deep, you see, and to correlate with all images later, inshallah. We'll try. Why not try to make it hybrid lectures, pathology, radiology. Try to prepare it from your side, and I will try to prepare a separate lecture, not like this, separate lecture regarding these new classifications. You see?
Very interesting.
Regarding all images, and do the pathology part, and present it as two part.
Yeah, I can take, yes, okay, we can do that, yes.
Later, inshallah.
Inshallah, that would be lovely.
Thank you very much, Dr. Nadia.
Thank you so much.
I enjoy your discussion, you and Dr. Rihab and Suhair, and I don't know who else is there.
Thank you.
Thank you so much.
Thank you for your so much, Rabab.
Not for my duty. I enjoy this lecture with you, the discussion with you, and I can say goodbye if you have nothing. You have no more question, we can leave it. Okay. Do you have any questions? Other audience?
Nobody's saying it.
Other audience, do you have questions? Dr. Aida. السلام عليكم. السلام عليكم دكتور عايدة، ازيك؟ احسن الله عزاكم.
عليكم السلام والرحمة. ازيك يا رباب، كيفكم؟
السلام
عليكم. والله دكتورة عايدة.
السلام عليكم دكتورة عايدة. أحسن الله.
عليكم السلام والرحمة، كيفكم؟ معلش وحصلتكم متأخرة، أظن التوقيت ما وقع لي كويس.
أيوة، أحسن الله عزاكم دكتورة عايدة.
الحمد لله الحمد لله، إنا لله وإنا إليه راجعون. الحمد لله الحمد لله.
عايدة البركة فيكم.
الله